Good morning, good afternoon, good evening. It's my pleasure to welcome you to this IDF-sponsored webinar on diabetes and kidney disease, the latest data from the IDF Diabetes Atlas and the iCaReMe registry. Next slide, please. I am Professor Edward Boyko, Professor of Medicine at the University of Washington and a staff physician at VA Puget Sound in Seattle, USA. I'm also co-chair of the Diabetes Atlas. Next slide, please. So welcome from IDF. I'm happy to welcome you on behalf of the IDF and go over some preliminaries about this webinar today. The webinar will be recorded. You can activate Zoom-generated subtitles by clicking on the closed caption, the CC button at the bottom of your Zoom window. Please note these subtitles are not 100% accurate. The recording slides and feedback questionnaire will be sent to all registrants in a few days after this webinar. Participants who attend at least 80% of this event live will receive an attendance certificate only if they complete a feedback questionnaire. Please check your spam folders if you have not received the feedback questionnaire by May 27th. Please use the Q&A function to post your questions to speakers and panelists. There's a Q&A button at the bottom of your Zoom screen. There will be 5 speakers today, and then there will be a question and answer session following the 5th speaker. Next slide, please. So I'd like to play for you a video, a welcome from the IDF president, Professor Akhtar Hussain from Bangladesh, Norway.
It's my pleasure to welcome all of you to this webinar that will discuss the impact of chronic kidney disease in people living with diabetes and the latest data from the IDF Diabetes Atlas iCaReMe registry. Diabetes is one of the leading causes for chronic kidney disease and end-stage kidney disease. In 2023, IDF Diabetes Atlas reported that approximately 30 to 40% of people living with diabetes develop chronic kidney disease. Furthermore, people living with diabetes-related kidney disease are at higher risk for cardiovascular disease, progression to kidney failure, and death. Professor Edward Boyko, co-chair of the IDF Diabetes Atlas, will present the latest data on diabetes and chronic kidney diseases from the latest IDF Atlas report. Most of this data is from high-income countries. Although countries with lower socioeconomic status experience the greatest increase in the number of people living with diabetes, there is clear need for tools to gather real-world data on the management of people with diabetes and kidney complications to provide adequate care, inform policy recommendations. Professor Carol Pollock will discuss present evidence from iCaReMe registry and explain how real-world data can help improve clinical care for people living with diabetes-related kidney disease. We also present the global advocacy agenda on diabetes and kidney disease and feature the perspectives of healthcare professionals and people living with diabetes, with representatives from IDF Young Leaders and Blue Circle Voice Networks. I wish you all an interesting and productive webinar. Thank you.
Next slide, please. So I will present the first talk on diabetes and kidney disease, data from the IDF Diabetes Atlas 2023 report. Next slide, please. So in addition to the Diabetes Atlas, which is produced concurrently with the IDF World Congress, we've started producing reports between the main Atlas editions. There was a report on diabetes and kidney disease, which was produced in 2023 and is available on the diabetesatlas.org webpage. shown here on the slide, also available through the QR code. And I'll be presenting some results from this Atlas report in this talk. Next slide, please. So what is chronic kidney disease? It's rather complicated. It's based on the glomerular filtration rate, or otherwise known as GFR, which is the ability of the kidney to secrete toxins and excess water into the urine, and also leakage of protein or albumin into the urine. There are 5 stages of chronic kidney disease. Normal GFR is generally felt to be a GFR of 60 or above. And so if albuminuria, though, is present, then this would result in the person being classified as having stage 1 or stage 2 chronic kidney disease, depending on the GFR. Stages 3, 4, and 5 are based on the GFR, and a lower GFR is translated into a higher stage, with kidney failure being stage 5, which I'll talk about more in a minute. First animation. Albuminuria is usually the first sign of diabetic kidney disease. The next animation shows you what the levels of albuminuria are that would qualify someone as having chronic kidney disease and diabetes or in other conditions as well. Next slide, please. So I want to draw a contrast between acute kidney disease and chronic kidney disease. Acute kidney disease is potentially reversible, and it's not progressive if the underlying cause is removed, usually not progressive. And there are many causes such as infection, obstruction of the ureters or bladder outlet, medications such as aminoglycoside antibiotics, toxin exposure such as lead, and even dehydration. Chronic kidney disease, on the other hand, is progressive. It's caused by underlying systemic condition or local disease confined to the kidney. Examples of systemic conditions are diabetes, hypertension, systemic lupus erythematosus. Local conditions, examples are glomerulonephritis and polycystic kidney disease. End-stage kidney disease is the final stage of chronic kidney disease, or stage 5, where the GFR is less than 15 mLs per minute per 1.73 meters squared. It's fatal unless treated with renal replacement therapy. I'll mention, though, that most persons with chronic kidney disease due to diabetes or hypertension do not progress to end-stage kidney disease and require renal replacement therapy. Next slide, please. So what are the signs and symptoms of chronic kidney disease? Well, uremia is the manifestation of end-stage kidney disease. And you can see here there are many symptoms such as nausea, vomiting, encephalopathy, pericarditis, acidosis, hyperkalemia, edema, anemia, metastatic calcification, renal osteodystrophy, and death. Stage 3 to 4 chronic kidney disease does not result in uremia, but does increase the risk for cardiovascular disease and diabetic lower limb amputation. Next slide, please. So what are the chronic kidney disease causes? Well, the highest cause is diabetes, which is estimated to cause over 40% of cases of chronic kidney disease, followed by hypertension or high blood pressure. Intrinsic renal diseases maybe cause about 8 to 9%, and then the remainder due to other causes. Next slide, please. I want to digress and mention the 10 editions of the IDF Diabetes Atlas, which have been produced, the most recent one in 2021, to give you an idea of how many diabetes cases we can expect in the future and how many are present now. Next slide, please. So in the 2021 edition, we estimated that there were 537 million persons worldwide with diabetes, and we predicted that in 2045, there would be 783 million, a 46% increase. And let me just mention here that in most Atlas editions in the past, where we've predicted how many diabetes cases will occur in the future, we've underestimated. And what's shown here in the background is the map of the 7 IDF regions, and I'll draw your attention to the lower left hand. Africa, which is going to, which we predict will have a 134% increase in diabetes between now and 2045, more than a doubling. Next slide, please. So let me present some information from the Diabetes Atlas report. There's been a substantial change in the number of worldwide chronic kidney disease cases. In 1990, there were about 1.3 million. In 2017, about 2.3 million. This is a 74% increase, mainly due to an increase in the number of persons with diabetes. Oddly, the age standardized global incidence rate of chronic kidney disease decreased slightly from 31.92 in 1990 to 29.15 in 2017 per 100,000. There's a 1.3 to 4.3-fold higher odds of chronic kidney disease in persons with compared to without diabetes. And 1/3 or more of adults with type 2 diabetes are estimated to have chronic kidney disease. Remember, there are 5 stages. Next slide, please. So here is information from the National Health and Nutrition Survey conducted in U.S. adults with diabetes over a 20-year period, as shown on the x-axis from 2001 to 2020. The prevalence of chronic kidney disease ranges between about 35% to about 41% over this time period, as shown by the purple line on the top. The green line is the prevalence of chronic kidney disease among U.S. adults without diabetes. The broken line is the overall prevalence. Next slide, please. So what about causes of end-stage kidney disease in the US and elsewhere? There's excellent data from the US because there's a payment system for dialysis that's national in the US that tracks all people on renal replacement therapy. And the most common cause of end-stage renal disease in the US is diabetes, followed by high blood pressure, followed by the other causes I mentioned earlier. In 2020, there were 807,920 persons in the US renal data system on renal replacement therapy. And in 2020, there were 34 million people with diabetes in the US. So the prevalence of end-stage kidney disease in persons with diabetes in the US in that year was 2.4%. Next animation. So the proportion of patients worldwide with end-stage kidney disease who have diabetes increased from 19% in 2000 to 28% in 2017. Next slide, please. So end-stage kidney disease formerly was known as end-stage renal disease. It's treated with renal replacement therapy, hemodialysis, peritoneal dialysis, or kidney transplant. Globally, 27% to 53% of persons requiring renal replacement therapy are estimated to have access to it. Access is limited in low and lower middle income countries. And remember, without renal replacement therapy, chronic kidney disease is fatal when it's stage 5. The highest incidence of end-stage kidney disease is found in higher income countries such as US and some Asian countries. The prevalence of treated end-stage kidney disease, regardless of cause, varies by country, income level per million persons. In high-income countries, it's 966 per million. In lower income, only 4 per million. Next slide, please. So this graph here shows the average yearly change in the incidence of treated end-stage kidney disease attributed to diabetes by country and region. This is from the Atlas Report over a 10-year period, 2010 to 2020. The greatest increase is shown at the top in Republic of Korea, followed by Singapore and Qatar, and other high-income countries show an increase in the incidence. There are a few exceptions to this, such as Austria and Italy, where actually the incidence of treatment for end-stage kidney disease actually fell over this 10-year period. Next slide. So conclusions, chronic kidney disease remains a continuing cause of morbidity, mortality, and economic loss in persons with diabetes worldwide. Prevalence shows little change over time, despite the demonstration of reduced renal complications with better glycemic control. And this was shown initially, I think, at the Diabetes Control and Complications trial in type 1 diabetes back in the early 1990s. Financial barriers prevent some patients with end-stage kidney disease from receiving life-extending renal replacement therapy. Newer medications, such as the SGLT2 inhibitors and GLP-1 receptor agonists, have demonstrated benefit in slowing the progression of renal disease in persons with diabetes, but costs may be prohibitive for many. The prevention and treatment of chronic kidney disease remains a continuing challenge for diabetes caregivers and patients. Next slide, please. Thank you for your attention. On to the next speaker. So it's my pleasure to introduce Professor Carol Pollack, a professor of medicine from the Northern Clinical School, the Coling Institute of Medical Research, University of Sydney, Australia, who will talk on real-world evidence in improving diabetes kidney disease clinical care insights from the iCaReMe Global Registry. Professor Pollack.
Many thanks for that introduction. Next slide. So the iCaReMe Global Registry is a prospective multinational, multi-centre observational study that collects data on the management and quality of care in patients with chronic kidney disease, type 2 diabetes, hypertension, and heart failure. And in this registry, we examined the baseline characteristics and the treatment patterns of adults with chronic kidney disease and type 2 diabetes enrolled between February of 2018 and December of 2022 in 21 countries across multiple WHO regions. Next. So if we look at the objectives, they were really to describe in real-world settings the socio-demographic and clinical characteristics of these patients, looking at disease management patterns for primary disease and comorbidities, including screening, diagnosis, and treatment approaches, and also looking at healthcare resource utilisation and clinical outcomes. I won't be discussing all of these today as they're ongoing. Next. If we look at the regions that are involved, we can see that they do span the higher and the lower socioeconomic regions, and they're from multiple different countries. And it's great to see so many people from these regions on the webinar today. Next. So if we look at the baseline demographic and clinical characteristics of these patients, they're fairly typical of the patients that we see in our practice. So the mean age was about 62, 63 years. About half were female, and the body mass index was high, as we would appreciate occurs in people with type 2 diabetes. Blood pressure was relatively well controlled, with a systolic blood pressure of 133 and a diastolic blood pressure of 77. We appreciate that studies have suggested that it could be potentially lower than this, but overall, not too bad. Hemoglobin A1C was less than 8% in 62% of patients. But there was, a significant number of people who didn't have optimal glycemic control. If we look at the overall characteristics, the serum creatinine was 1.8 milligrams per deciliter, which translates to an eGFR of 48 mils per minute, which means that on average, people had stage 3 chronic kidney disease, and we can look at that breakdown in a bit more detail. And many people had an elevated urinary albumin to creatinine ratio, which in these units are, in older terms, macroalbuminuric on average. And there was significant comorbidity, with approximately a third of people having coronary artery disease and 41%, really by design of the inclusion criteria, having heart failure, and 6.1% having had a stroke. Next slide. So if we break down the KDIGO GFR categories, as we've just heard, we can see that there was a significant number of people with quite impaired kidney function. So just over 20% had a GFR between 45 and 60 mils per minute. So category 3A, chronic kidney disease. But a significant group of people had a category of 3B, which is a GFR between 30 and 45, where we recognise that significant complications occur. And importantly, about 25% had stage 4 or 5 chronic kidney disease, which is obviously associated with progression to end-stage kidney failure, but also significant cardiovascular morbidity and mortality. If we look at the albuminuric rates, we can see 47% had category A2, which was what we used to regard as microalbuminuria, but about 30% had macroalbuminuria, and about 24% had normal albumin in the urine. But we recognize that albuminuria at any stage above normal, which is of course about 30 milligrams per gram, is associated with significant complications independently of what the GFR is. So a GFR of less than 75 and any degree of albuminuria is associated with an increased risk of mortality. Next slide. So if we look at this data that really puts in kidney disease as a global health priority, it comes from from Nature Reviews Nephrology from earlier this year. And we know that the WHO considers cardiovascular disease, cancer, respiratory disease, and diabetes as important non-communicable diseases. It doesn't include chronic kidney disease, and yet we know that chronic kidney disease has an increasing prevalence, an increasing mortality rate, and has catastrophic health expenditure associated with it. Its rates are increasing, largely due to the increase in diabetes across the world, whereas the rates of cancer and cardiovascular disease are not increasing to the same extent. And if we look at the years of life lost, we can see that chronic kidney disease accounts for there will be 100% increase in years of life lost between now and 2040. We know that if you start dialysis at the age of 40, you have the same risk of dying as a 75-year-old in the population. And we know that the costs are catastrophic. They're more than any of the other non-communicable diseases. And as an example, if we look at sub-Saharan Africa, we understand that only 10% of people with end-stage kidney disease can afford to be on dialysis for 3 months, and only 1% of people can afford to be on dialysis for more than a year. And of course, then there's the environmental impact, which is huge for kidney disease with respect to waste products, to electricity use, to water use, and to the carbon footprint. Next slide. So in terms of management, we understand that RAS blockade has been the cornerstone of management for diabetic kidney disease and chronic kidney disease, really dating back to the early 1990s, and for diabetic kidney disease for the early turn of the century. And all of the global guidelines suggest that we should be using ACE inhibitors or angiotensin receptor blockers in the maximum recommended dose, as we understand that if there's a reduction in the recommended dose or cessation, those are equivalent in increasing the risk of cardiorenal outcomes and increasing mortality. So best practice is we need to maximize these the use of these agents to the optimal dosages. Next slide. More recently, we've understood really since the cardiovascular outcome studies from EMPA-REG initially in 2015, so incredibly almost 10 years ago, and subsequently the CANVAS program using canagliflozin, DECLARE using dapagliflozin, VERTUS using ertagliflozin in secondary analyses, and also in the CREDENCE study. All of these patients had diabetes, and all of these studies demonstrated a significant risk reduction in either primary or secondary endpoints of developing end-stage kidney disease, a reduction in GFR, or death due to kidney disease or cardiovascular disease. Next slide. So if we look at dapagliflozin in the DAPA-CKD study, it enrolled people with and without diabetes, and across the board there was a significant reduction in these hard renal endpoints in people with and without diabetes. Next slide. If we look at the outcome studies with EMPA-Kidney using empagliflozin, we can also see that there was a 28% risk reduction in people who were treated with empagliflozin with respect to cardiovascular death or kidney progression, reduction in all-cause mortality. And because of the relatively increased number of people without diabetes, there wasn't an increase, there wasn't a benefit in hospitalization for heart failure, cardiovascular, or all-cause death. Next. So if we look at the people who were treated with SGLT2 inhibitors in these meta-analyses, we can see that for every 1,000 patients with chronic kidney disease and type 2 diabetes treated for 1 year with an SGLT2 inhibitor, there would be 11 fewer patients that develop kidney disease progression, 4 fewer patients have acute kidney injury, as we know that SGLT2 inhibitors prevent acute kidney injury, even though there is an immediate drop in GFR with the commencement of treatment. And we also know that there's 11 fewer cardiovascular deaths or hospitalization for heart failure, with very few side effects. Next slide. So when we look at the guidelines for management, and if we look particularly at the KDIGO guidelines, but across the board there's similar guidelines, it really suggests that we should be using SGLT2 inhibitors in people with chronic kidney disease and diabetes, and this is irrespective of glycemic control. And this should occur with adults with a GFR of anything above 20 mils per minute and albuminuria of more than 200 milligrams per gram. Now, that is level 1A evidence, and the EMPA-Kidney study also suggested that we should be treating people with lower levels of GFR with lower levels of albuminuria. Now, that hasn't been accepted in Australia by the reimbursement authorities, and we're still looking at reimbursement only if there's significant albuminuria. Next slide. If we look at the use of finerenone, which has been shown in the Fidelity analysis, which was a combination of Figaro and Fidelio to combine to Fidelity, we can see that there was a 23% risk reduction in people with diabetes in terms of the kidney composite endpoint, and a 14% reduction in the cardiovascular composite endpoint. Next slide. And that has also led to KDIGO suggesting that if people have residual albuminuria when they've been treated with appropriate levels of RAS blockade and SGLT2 inhibitors, they should be treated with a non-steroidal mineralocorticoid receptor antagonist. With
Professor Pollack, meeting organizers asked me to ask you to wrap up in 1 minute, please.
Sure. Okay, next slide. And of course, we have the FLOW study that's reading out on May the 24th at the European meeting, which is demonstrated, next slide, to show a 24% reduction in the risk of kidney disease-related events in patients with type 2 diabetes. And we're interested in the analysis of that, which we'll know within the next week or so. Next slide. So if we look at the evidence, we should really be using SGLT2 inhibitors, potentially GLP-1 receptor agonists, but the data suggests that we're not optimally treating our patients with diabetes and chronic kidney disease with appropriate therapies. And overall, only 36% of people who should be treated with an SGLT2 inhibitor are being appropriately treated. So there is a huge treatment gap. Next slide. So I'll just wrap up with the high economic and environmental burden that kidney disease is predicted to incur by 2032. And we can see here the huge increase in cost and the huge increase in environmental impacts. And I'll finish up there.
Thank you very much. My video is not enabled right now, but I'll go ahead and thank Professor Pollack for her presentation. And it's my pleasure to introduce our next speaker, Dr. Mashari Al-Asiri, who is a medical intern, who is an IDF Young Leaders and Diabetes Mentor and Middle East North Africa region representative from Saudi Arabia, who will speak on how healthcare professionals can work better with people living with diabetes.
Hello, everyone. Thank you for this opportunity, and I would like to thank all the participants for attending today. So today I'm going to talk about our aspect as people living with diabetes when it comes to how we perceive complications and how we perceive the approach of the healthcare professionals regarding them. And I will give some tips and examples of the education methods that are not liked by us patients. And I want to hear your thoughts at the end of the talk. Next slide, please. So diabetes care is multidisciplinary, and diabetes education is too. And it is highly tailored according to each patient's background, habits, knowledge. Since people living with diabetes have various levels of knowledge, perceptions, and expectations regarding the amount of information that they need. Our goal is to treat our patients as a whole, which includes their psychological well-being. This is very crucial when it comes with dealing with chronic diseases, especially diabetes. So let's take a few examples. So let's say we have Muna, who is 25, young lady, and she is a school teacher. She's married and came with a positive OGTT. After further testing, she was diagnosed with GDM. She doesn't know anything about diabetes. So how can we approach her regarding education, especially when it comes to complications of GDM and how she can prevent it? I believe that assessment of her knowledge regarding diabetes is very crucial, and then we can move on forward. And we should give her small digestible bits of knowledge so that she can understand and then manage herself accordingly. And I'm sure that as soon as she leaves from the office, or even before entering, she's going to read about GDM. And the information tends to focus on the complications more than the ways of dealing with it and the experiences of people who are living with GDM, which can be frustrating and frightening. Another example of someone whose name is Khalid. He's a 35 years old man and has been living with diabetes for 20 years. Now he was found to have nephropathy, let's say stage 1, and he is concerned about it. So how can we approach him? I believe that reassurance is very important because being concerned shows that he knows the seriousness of the situation. So we need to focus on encouraging him to maintain his health rather than warning him about deteriorating, as it could lead him to burnout and not take good care of himself. Also, I believe that noting that complications happen in stages is very important. So let's say, for example, in nephropathy, in the earlier stages, ACE inhibitors are all what's needed, ACE or ARBs, and we control the blood pressure, as well as taking good care of his diabetes. But in later stages, the management is different. Moving on to the final example, let's say we have Ahmed, who's 60 years old and was diagnosed with type 2 diabetes. He was instructed to see Ophtha to examine his retina, but he's reluctant and says that there is no need. So what can we do in order to educate him? So can we warn him about the complications in this stage? So yeah, the slides, all of this is in one slide. So I'm an intern. I don't have your expertise, so I would like to hear your thoughts whether telling him about or warning him about the complications is part of the management or not. Next slide, please. Okay, so here are examples of posts that educate about diabetes, and these posts have something in common. They all provide a little bit of information, little bit of pathophysiology, why it happened, and what the patients can do in order to overcome them. Okay, so these are the things that we care about the most. Next slide, please. Next slide. Yes. Okay, so these slides or these posters, I don't like them very much. The one on the left shows what people who have retinopathy, what their vision looks like. And I was once in a campaign and I wore a VR headset or VR glasses. And it was one of the worst experiences because I did not want to see that in the future. And in the right-hand side, it talks about nephropathy, which is good, but it gives details and numbers of like mortality, morbidity, and all that stuff. I believe that it is important when we are talking to each other in conferences, when we're reaching out to policymakers, that we bring those numbers. But when we're talking to patients, I believe that we shouldn't bring these numbers, especially mortality rates and all these stuff. And all this is not to shy away from these complications. They do happen and we need to address them. We need to talk about them. However, we need to put them in the right context. And thank you for listening. That is what I have today. Okay, yeah. So we can choose the right time, place, and stage to communicate. So choosing the right context. And we should encourage role models to speak up, both to people living with diabetes and healthcare professionals who are not directly taking care of people living with diabetes. Clarify the purpose of each intervention. So when we gave ACE inhibitors, we do not only tell them this is for your blood pressure only. We tell them it's for your blood pressure. It protects the kidney. So this would encourage the patients to increase their compliance. And we should manage the clinics and patient loads efficiently so that each patient gets his or her time, the time that they need. Thank you.
Thank you very much, Dr. Al-Asiri. So we'll go on to our next speaker, who is Dr. Valerie Lakes, who is the chair of the Advocacy Working Group of the International Society of Nephrology, and she is based in Switzerland, and she'll talk on kidney disease and the global advocacy agenda. Dr. Lakes.
Thank you very much, and thank you for inviting me and for inviting the International Society of Nephrology to this wonderful webinar. Next slide, please. So to begin with, just to remind everybody, we've already heard from the other speakers that the burden of kidney disease is high, but these in 2019, according to the Global Burden of Disease study, 3.1 million people died of kidney dysfunction. So next. So that means that one person every 6 seconds around the world died of kidney disease, and this makes kidney dysfunction the 7th leading global risk factor for death. Next. So this infographic really captures quite well the prevalences of the common or at least prioritized chronic non-communicable diseases These data come from the Global Burden of Disease study, and as we can see, there's a rather large elephant in the room. So the numbers above each of the figures is the millions of people living with these diseases. And according to the Global Burden of Disease study, almost 700 million people around the world are living with kidney disease from stage 1 through to stage 5, chronic kidney disease. Next. But what is extremely important is that kidney disease is actually related to each one of these priority non-communicable diseases. So kidney disease and heart disease are very strongly interlinked. Kidney disease is a major risk factor for death from cardiovascular disease, and cardiovascular disease is a major risk factor for worsening both acute and chronic kidney disease. Next. Kidney disease is also a risk factor for strokes, not only through hypertension, but also through exacerbation of vascular health. Next. Kidney disease is related to chronic lung disease, chronic respiratory disease, and there is the relationship between glomerular filtration rate and lung function. Next, the relationship between kidney and cancer is quite close because kidney function is often used to dose chemotherapy, and therefore, depending on what the patient's kidney function is, sometimes they may or may not be able to undergo certain types of chemotherapy, and then the cancer chemotherapies themselves at times can actually cause kidney dysfunction or hypertension. Next, and then most importantly, why we're here today is that there's a very strong link between kidney disease and diabetes. We've just heard that, and basically diabetes is a major risk factor for chronic kidney disease. So as we can see, this elephant in the room is highly linked to all the other non-communicable diseases that are prioritized on the global agenda. Next. So we've already heard that according to the World Non-Communicable Disease Agenda, there are 5 diseases that until 2018 have been prioritized. Oral health is now being added as a potential 6th. But next, we do remind people that kidney disease is not listed among these. However, we do need to be at least honest and say that the 5 risk factors that have also been itemized in this 5x5 strategy led by the World Health Organization, each of these 5 risk factors for all these 5 priority diseases also have a positive impact on kidney disease. And we've already heard that diabetes is driving at least part of this global kidney disease burden. So all risk factors that are going to drive down diabetes should also be helpful for kidney disease. So although kidney disease is not overtly prioritized, we do believe that there is at least some benefit that the kidney has probably gained. Next. However, what we have realized over these years is that it is crucial that kidney disease should be recognized as a priority disease, not only because of the large disease burden, but also because when diseases are taken account by the WHO and listed as priorities, countries take these and try to track disease burdens and try to develop disease programs. So what we have been trying to do at the ISN is very actively in our advocacy, trying to get a K back into the alphabet. And this is not only to focus on kidney, we're trying to stress that kidney disease and kidney health needs to be integrated in all other non-communicable disease programs, especially that of diabetes. Next. So the ISN is very, very active on the global agenda. They are putting together a lot of academic publications. We just heard from Professor Pollock about one of the most recent excellent overarching publications. The ISN has also developed a global kidney health atlas and is really active at the WHO level, being the only kidney organization in official relations with the WHO. So we are hopeful that we will improve advocacy for kidney disease and kidney health. Next. And World Kidney Day this year was very aligned with the theme of this webinar, really trying to call for kidney health for all, meaning advancing equitable access to care and optimal medication practice everywhere. And we've heard already that there are global inequities in access to diagnosis and to care, and a lot of barriers why patients are not getting the medication that they should be getting. And so we need, as a global non-communicable disease community, to come together and try to address these. Next. So we basically need greater awareness of kidney health and its importance for health in general. We've heard already that 1 in 3 people with diabetes have chronic kidney disease. 1 in 5 people with hypertension have chronic kidney disease. The risks of chronic kidney disease are exacerbated with obesity. But next, only around 80% of people are aware of their chronic kidney disease in some sorry, 80% are unaware of their chronic kidney disease. In some places, 90% of people are unaware. So this is extremely critical that we raise awareness of chronic kidney disease. Next. And so how do we advance kidney care? And here I have just a picture of the WHO report on tracking universal health coverage, which is really an absolute necessity for people with chronic diseases who need chronic access to quality care. We need accurate data on disease burdens, greater awareness of risk, affordable, acceptable, and equitable access to care, including diagnostics and therapeutics. We need fair prices for life-saving medications so that these are affordable for everybody. We need an empowered and an educated health workforce to raise awareness amongst the health workforce and the patients. And we need to empower patients and communities, as we've just heard beautifully, that patients are really the main people looking after themselves. And so we need to work towards working with them to manage their own health better. Next. So thank you very much.
Thank you very much, Dr. Lakes. We'll move on to our last speaker, Mr. Michael Donahoe, founder and program lead, Donahoe Diabetes, IDF Blue Circle Voices member from the United States, who will talk about living with diabetes and kidney disease. Mr. Donahoe.
Thank you very much. I want to thank everybody today for coming on, because I know everybody's coming from all over the globe. And I want to thank the speakers, because a lot of the data really does support the information I provide. And thank the IDF team as well for setting this up. So next slide, please. Next slide, please. Okay, I'm not seeing the switch in the slide. There it goes. Okay. The reason why CKD is so important to myself and my family is that CKD, my father had T2D, type 2 diabetes. My grandmother had type 2 diabetes, as well as my many members of my family. But my father passed in 2006 from CKD, and my grandmother in 1977. They called it congestive heart failure, but as discussed, cardiovascular disease is a key part of this. I also live with cardiovascular disease and hypertension. My diagnosis came in late 2019, which of course was right before the pandemic. And I'll give you the emotion, which was simply I cried, and it appeared to be a death sentence. It's what our family could really only knew it to be. But I think the most important part for me was my healthcare team worked with me to take action. And the nephrologist, my cardiologist, and primary care physician worked together to stabilize the conditions, especially again through the pandemic, which was not easy. And I also learned early on to start self-advocating. Through open heart surgery and some other, take their advisement and seek more information from sources like the IDF. Next slide, please. Okay. The results throughout 2020, the pandemic, we went into action. I took time to meet with a nutritionist who educated me on the best ways to lower protein, potassium, and phosphorus levels in the kidneys and urine output using dietary pathways. The doctors removed and replaced a triglyceride medication, Tricor, with an omega-based RX. That's because I deal with triglyceride issues. Two specialists also recommended SGL2, which brand name Invokana in the States, to improve urine throughput to help kidney function and remove sugars. My PCP was not sold on the idea. Somehow, through our advocacy, through my self-advocacy, he allowed it to go into my mix, and it has helped. Being a results-oriented person, because I work in project management and healthcare and digital, kidney stabilized in 6 months and confirmed after 1 year. And as of 1 year ago, May 2023, the kidneys continue to be stable. But next slide, please. Okay, I'm going to keep on speaking. I'm not seeing the next slide. So for me, I must keep success in today. Living with type 2 diabetes is an all of the time job. Some people like to call it another full-time job. It's all the time. Living with kidney disease, heart disease, diabetic retinopathy, diabetic neuropathy, and mental health factors of anxiety and ADHD are directly affected by my T2D, plus other conditions. Again, mentioned my diagnosis, I cried. I think it's key to see this death sentence comment. I'll make a comment at the end. My upcoming kidney appointment is next week. So I get to do all the blood tests on Monday. And then by the end of next week, I will know how I'm doing. Down about 5, but we're working on it. Key to remember in diabetes life is you are only on target if your numbers are on target. Again, that's reminded to me more than once. Blood sugar and all required blood tests. Best way to handle CKD from the point of living with it is to live your life with diabetes. Don't forget that. Proper nutrition, exercise, medical professional cooperation, stress levels, and sleep. And just a reminder, be mindful of protein, potassium, and phosphorus intake, because all of those items are going to be part of what's discussed with your physician. One comment I'm going to throw in too. Comment about the GLP-1. We discussed I'm putting me into a GLP-1. I'm on a short-acting and long-acting insulin. Decision at least made in January was not to move me to that, but my cardiologist and my nephrologist will have input over the next month to see if it's something I should move to use. Thank you very much. Appreciate everybody's time.
Thank you very much. Now the meeting switches to the discussion, and the panel will hopefully appear here on video, and then we'll conduct a question and answer with the questions you've submitted. Let me start with a question here. This is for Dr. Lakes. How can we best prevent kidney disease from diabetes around the globe, especially low and middle income countries?
Thank you. That's actually an excellent question, because I think diabetes is definitely an important cause of kidney disease in low and middle income countries, but there are also other causes of chronic kidney disease. In many places, we don't even know what the real causes are, because unfortunately people in low and middle income settings don't have much access to diagnosis. A lot of them have to pay out of pocket. So I think what's extremely important is that we work also with policymakers to try to implement policies that might reduce diabetes, reduce obesity, try to make greener cities, healthier cities where people can exercise, make sure people have access to universal health coverage, so that if they do have problems like diabetes, hypertension, or even impaired glucose tolerance before they develop diabetes, these things are diagnosed early and can be managed early and appropriately, with sustainable access to affordable and quality medication and diagnostics and clinical care. And all of that hopefully will actually add towards improving and decreasing the risk of kidney disease and improving kidney health. Thank you.
Thank you very much. So the next question for Professor Pollack. What interdisciplinary collaborations are driving innovation in the treatment of diabetes-related kidney diseases, and how do these partnerships benefit patients in terms of improved therapeutic options and outcomes?
So that's another excellent question, because I think that traditionally we've been operating in silos. So we look after people with chronic kidney disease, you look after the glycemic control, other people look after the heart disease, but we really need to be looking at the patient who presents with all of these problems. So when we look at trying to best treat somebody with diabetes, we need to be looking at glycemic control, trying to prevent or control chronic kidney disease and control heart disease. So there's lots of treatments to improve glycemic control. There's treatments to improve kidney disease and heart disease. But when we look at the intersection, we can see that RAS blockade improves kidney outcomes and heart outcomes. We look at SGLT2 inhibitors that improve glycemic control, kidney outcomes, and heart outcomes. And now we look at GLP-1 receptor agonists, and they also improve glycemic control, kidney disease, and cardiovascular outcomes. So I think it becomes quite tricky for the generalist to look at how best to manage somebody with diabetes, because it's not just glycemic control. We need to be looking at managing we need to be shifting our focus to managing the complications. So I think SGLT2 inhibitors, RAS blockade, GLP-1 receptor agonists, and finerenone are really our armamentarium at the moment. And there's lots happening in the research front to look at other therapies to improve the outcome for people with diabetes.
All right, thank you. So the next question is for Mr. Donahoe and Dr. Al-Asiri. How can patient adherence to treatment plans be improved in those with both diabetes and kidney disease?
Please go, doctor.
Go ahead.
I think it's a little bit of a difficult question, other than at least from the point of view of the patient who's in a non-medical background. But the key thing is the communication and the discussion and the awareness of the different treatments. At the time of the SGL2 being suggested to me, I knew of the medication. I knew basically what it would do, but I never even thought of it to be used as a choice. So in switching the triglyceride med, which again, I did not realize there was an issue with that med, and I had been on it for probably a good 20 years. And the second thing is with the SGL2, it's just, it did improve, it did extend the time frame of my needing to focus on the CKD, and it was able to be managed by my PCP. And I'll pass that over.
Dr. Al-Asiri, how can
Yes,
patient adherence to treatment plans be improved in those with diabetes and kidney disease? Is the question.
Okay, so from my experience, I can only talk about living with type 1 diabetes. I'm not living with chronic kidney disease, but to answer that question, when it comes to increasing adherence and diabetes in general, positive feedback plays a huge role. When we go to our doctors and we hear encouragement, we tend to do our best. And when we're selecting the types of treatment, an open discussion about the types of treatments, the side effects. So an interaction between us as patients and doctors is really important. So it's not doctor says and then we do. It's from both sides.
Okay, thank you. So here's a tough question. In some countries, there are no dialysis machines. How can we help our patients with stage 1, 2, and 3 kidney disease? This was directed at me, but I'd like to share it with the others on the panel here. So if this is a country with no dialysis machine, I'm assuming this is a lower income country. So what I would recommend to prevent progression of stage 1, 2, and 3 kidney disease would be to choose the inexpensive treatments that are available to achieve better glycemic control. And then, of course, remember the information I showed you about hypertension contributing to chronic kidney disease. I would recommend also intensifying treatment of hypertension, and there are many inexpensive medicines. So essentially, pull out all the stops here to prevent progression of chronic kidney disease by keeping glucose at an acceptable level and by also keeping blood pressure at an acceptable level. And so I'll ask Professor Pollack, Dr. Lakes. Dr. Lakes, you have your hand up. What would you suggest? Thank you.
Yes. Thank you. Yes, I think this is an area really where the ISN is very much trying to raise advocacy, because the problem is in most of these places, people are not diagnosed before they are in stage 5 in the emergency room with terminal uremia and needing dialysis for life, and they can't afford it. The problem is, as you said, there are inexpensive medications for high blood pressure and diabetes. But when you have to pay out of pocket and you're earning very little, these medications become very expensive. There was a recent analysis that showed that one antihypertensive for 1 month can cost between 2 and 6 days of wages in low and middle income settings when people are paying out of pocket. And as we know, people with kidney disease, hypertension, cardiovascular disease land up on 5 or 6 or 7 medications. So we need to find a way that these people have access to diagnosis as early as possible, so that we have a fighting chance to save the kidneys and prevent deaths and morbidity from cardiovascular disease, treat the diabetes, obviously, and we need there to have affordable medication, that people do not go bankrupt and fall into poverty not being able to pay for the medication, and that the diagnosis is really an accurate diagnosis, and that people get good follow-up. So I think the problem is, the fact that we have cheaper medications in the high income settings does not mean that these medications are affordable in low income settings without appropriate support and access to care and universal health coverage.
All right, thank you, Professor Pollack. Dr. Al-Asiri, any additions on that point? No? Yes, go ahead.
I think there's probably all of the issues that Valerie has suggested, but I think that the WHO have now recognized that SGLT2 inhibitors are essential medicines. So that does make it a little easier for people with early stage kidney disease to access them. I'm not suggesting that it's going to be completely cost-free, but I think there is a worldwide recognition that diabetes and kidney disease are so expensive for low and middle income countries that it's worthwhile investing in SGLT2 inhibitors. So apart from non-smoking, control of obesity, and obviously blood pressure and glycemic control, with metformin, I think has been also demonstrated in secondary analyses to prevent or to reduce cardiac and kidney complications.
Okay, thank you. So this is questions for you, Professor Pollack. What whole population strategies could be implemented to reduce the incidence of diabetes and its complications?
Oh, well, I think it does depend on policymakers and politicians to have a willingness to implement. And I think screening is a good start. Previously, even high-income countries such as the US didn't accept screening because it wasn't, there was no good treatments. But in 2020, the US agreed that screening was going to be beneficial because strategies such as SGLT2 inhibitor use justified the cost of screening. So I think targeted screening for people with diabetes, but also people with cardiovascular disease, hypertension, obesity, people over the age of 60, Indigenous populations, and people with a family history should be screened and then treated appropriately. And that will reduce the expenditure for people with kidney disease and diabetes in the longer term, because we fully understand it's a huge cost to the economy, to the taxpayer, etc. So if in Australia, we've calculated that investment in screening will save about 230,000 cardiovascular admissions, and it will save 38,000 deaths and probably 68,000 people from ending up on dialysis in their lifetime. And for every dollar invested, there's a $45 saving by virtue of early screening for chronic kidney disease. So it's a long-term investment. but it should be adopted by every country, really.
Thank you. So I have a question here for Dr. Al-Asiri and Mr. Donahoe. Let's start with Dr. Al-Asiri on this one first. How does stress and mental health affect diabetes management and kidney health, and what strategies can be implemented to address these factors early on?
It affects it greatly, starting from the motivation to even follow up with taking the meds, putting on the sensors. There were some days where you just feel like it's too much. Whenever I'm changing the sensor, I would take like 1 or 2 days off. I think it's okay to take like a day off, but it shouldn't be a long time. Also, I think, losing motivation, being stressed, having anxiety, thinking about complications, all these can affect the management, whether by preventing us from taking the medications and managing ourselves, or like biologically. So if we're stressed and if we're thinking about it all the time, of course, it's going to affect the blood glucose. It's going to affect our exercise. So it affects us in many, many ways. I believe that in order to overcome this, we need to have a good support system. So having friends and family, talking to your healthcare provider. I always talk with my doctor about this, and she's very supportive. And a community, a diabetic community helps a lot. So here in Saudi Arabia and Twitter, we use it to communicate our feelings with dealing with diabetes, and it helps a lot to see other people living with the same thing. You feel that you're not alone. Yeah.
Okay, thank you very much, Mr. Donahoe. I can repeat the question if you like.
Please do, just to make sure.
Yeah, sure. How does stress and mental health affect diabetes management and kidney health, and what strategies can be implemented to address these factors early on?
Okay, well, with me, it's like I've lived with general anxiety disorder and ADHD. Only found that one out in my late 30s. But I think the biggest thing for me is making sure I keep the information in front of me, because if there isn't some pressure or stress that's coming from one side, being a father of 5 kids, and or the health or a job, or even, helping out in situations like being a panelist. It's type of thing where I try to be very methodical on how I handle this and try to identify the areas that actually help me. For my wife, it's exercise. I don't love exercise. For me, it's a guitar. I like my guitar. It's what allows me to take the time to release the stress. But I think one of the keys, and I mentioned it earlier also, is sleep. Making sure that you're on a very good sleep schedule. You're taking the time to move. You're taking the time to eat right. Taking your meds at the right time. So this is why I said it's more than a full-time job. It's an all-the-time job. So if you can, but you're going to hit those spots, and and I think the most important for me is to forgive myself. I forgive myself, and I do monitor each of the conditions carefully. And, that's the main thing. But forgive yourself. Every day is a new day. You wake up, you have a whole new chance at life. So pretty much that. Be positive.
Sounds optimistic. Thank you.
Thank you.
Yeah, Dr. Lakes, question for you. What are the challenges in diagnosing and monitoring kidney disease in patients with diabetes, and what strategies can be employed to improve early detection and intervention?
So again, I think we keep coming back to this equity question. I think huge challenges are lack of diagnostics. So for example, serum creatinine is not available everywhere, needs to be often paid for out of pocket. So this is a problem. I think there are screening camps often where people do sugars and measure blood pressures, but they can't afford to look for urine microalbuminuria, and they cannot afford to look for the creatinine kidney test. So these are major barriers in terms of diagnosis. But I do believe that if we increase awareness amongst the general population, amongst the clinicians, and amongst the policymakers, that it would be a win-win. As we heard from Professor Pollack, if we screen and treat these people early, we can save a huge amount of money down the line if the government provides a service. So I think we need access really to diagnosis and improved awareness across the board. Thank you.
Okay, thank you. So here's an interesting question for Dr. Pollack. Has treatment of diabetes become too complicated for the primary care physician?
Look, I think that it is difficult for the primary care physician to keep up with all of the developments in treatment of diabetes. And I think that diabetes treatment has previously focused on glycemic control, and there's multiple treatments for glycemic control. But I think we've moved on from that, and now we need to look at control of complications. So I think the primary care physician is faced with multiple areas of educational need, and diabetes is, a burgeoning need. So education is extremely important. And I think, everybody can't be referred to a specialist. And so education for the primary care physician is really important. But I think, to keep it simple, I think metformin should be the backbone of treatment for type 2 diabetes, and then SGLT2 inhibitors to prevent complications, or if they exist, for heart failure, for kidney disease, as second-line therapy, as DPP-4 inhibitors tend to be second-line therapy, but they don't have concomitant benefits in organ protection for heart or for kidneys, as demonstrated in appropriate long-term studies. So I think there needs to be a shift so that people are more comfortable using SGLT2 inhibitors, maybe GLP-1 receptor agonists, although it's an injectable at present in the majority of cases. So I think it's, generational to some extent. It's educational, but I think we need to be shifting from glycemic control to whole of patient benefit.
All right, thank you. So just wondering, Dr. Lakes, Dr. Al-Asiri, do you have any opinion about this? Has treatment of diabetes become too complicated for the primary care physician?
I agree. I agree with Doctor. I'm now an intern. I'm rotating at all the specialties. Even though I've been living with type 1 diabetes, it's becoming much more complicated. But the newer generation of doctors are up to the challenge, inshallah.
So I have an opinion about this. It's difficult in higher income countries to keep up with the diabetes technology. In my opinion, how to maintain closed loop hybrid systems and 24-hour continuous monitors. So anyway, it's because of medical progress. All right, so let's see here. Here's one question, and it's directed at me, but I'll also ask panelists for their input here. Why hasn't prevalence of chronic kidney disease and diabetes changed much since 1990, considering there have been improvements in diabetes care, including better glycemic control and use of ACE inhibitors and angiotensin receptor blocker medications, which preserve kidney function? And I don't know the answer to this question, why the prevalence has not decreased, because the Diabetes Control and Complications trial in the early 1990s reported an improvement with prevention of kidney disease with intensive glycemic control. And then there have been clear demonstrations of benefits of ACE inhibitors and angiotensin receptor blocker medication. And of course, more recently, there are the SGLT2 inhibitors, GLP-1 receptor agonists. But if we're talking about the past few decades, I don't have an answer to this question. Do any panelists have any ideas about this?
And I think one of the things that at least happened was that it didn't rise further. So somehow I think there was some benefit, but I think one of the important factors is that the uptake has never been optimal. And so we just saw now that at maximum around 30% of people with an indication for an SGLT2 inhibitor leave hospital with one, and then sometimes 5 or 10% are still on the medication at 3 months. In terms of the ACE inhibitors as well, around 60% of people with an indication seem to be on them. Part of this is that there is not awareness. I think one of the issues as well is that sometimes there are small complications and the medicines get stopped and not restarted. So I think one of the things we were looking at the World Kidney Day campaign in trying to optimize medication use for everybody was looking at these barriers within the clinician, primary care offices. Do they have too many guidelines? Are they overwhelmed with guidelines from all sorts of different directions? Should we really integrate so we make it simpler? Because I do believe it can be simpler, and they can also be primary care physicians with a special interest in something who can become as good as any trained specialist, nephrologist, endocrinologist. So I think we need to simplify things. I think patients, as we heard, need to look after themselves. And so adherence is an issue. And so there've even been studies really amongst chronic kidney disease patients who basically say that 30% of they do miss, 30% of people say that they miss medications, if not frequently, just every now and then. So, the continuity is also a problem. But I think one of the issues as well is that many people with kidney disease actually die of cardiac complications before they get to end-stage kidney disease. And maybe now some of those are also surviving to end-stage kidney disease because their heart disease is better treated as well with these drugs. So, I think we need to watch the space, because the projections now with the cocktails that we have are that we might be able to delay dialysis in some cases by 20 years in an individual. So hopefully some of this will pay off.
All right. Thank you very much. Any other opinions about this? All right. Well, since you mentioned cardiovascular disease, has presence of chronic kidney disease been incorporated into cardiovascular disease risk calculators? And I'll take on this question, and the answer is yes, it has. If you search for the PREVENT calculator of the American Heart Association, estimated glomerular filtration rate is now one of the entries in the calculator to predict cardiovascular disease risk, in addition to lipid levels and blood pressure, presence of diabetes, smoking, and the other conventional risk factors. Anyway,
maybe just add to that.
Go ahead, please.
Fact, in people, in nephrology circles, kidney disease is such a strong risk factor for cardiovascular disease. We almost don't need a calculator. If somebody has chronic kidney disease, they have the most enormous risk factor for cardiovascular disease, greater than diabetes. But if diabetes and kidney disease are both present, then it is much greater. So people who look after patients with chronic kidney disease often don't use risk calculators because lipids are often, the absolute levels are not helpful, but they have a dense, low density lipoprotein that is highly atherogenic, but the absolute level isn't necessarily predictive of cardiovascular risk. So we recognise that albuminuria in particular, and that's been incorporated into cardiovascular guidelines now, but a low GFR and the combination with albuminuria is very high risk, such that a calculator incorporating age, sex, lipids, diabetes probably isn't all that necessary.
Thank you. Mr. Donahoe, a question for you. Why did you decide to become an advocate?
Just making sure you can hear me here. The main reason why I came an advocate was because of my time. There we go. Mainly because when I went through the heart disease and I was going through a divorce and other things in the early 2010s, I realized I had allowed myself to slip, and I went myself into a position of hurting myself, basically, because I lived with the triglycerides There was a sign of the hypertension, and it just kept on growing. And I mean, as of this year, I will spend half my life on living with diabetes. So, and I think the comments that even everybody has said here is exactly key. It's still, to me, as things kept on coming along, diabetic retinopathy, neuropathy, you name it, I just have the whole gamut of it. It was even the point about, we have not seen individuals dying of end stage, kidney disease, but the world has changed. And, with both my direct relatives, direct bloodline passing from what I would say chronic kidney disease, but they called it again, congestive heart failure. It's just one of those things that I felt it was important. Also, my background has been in marketing, communications, and in policy. I've been focusing on policy. So I appreciate some of the comments everybody has said here I've been taking notes. And I appreciate that. And the reason why is, I should have said this in the opening, it's because I care about people. I care about where my families come from. I care about people. Nobody in this world globally should have to go through the health situations, since we have the ability, the knowledge, the capabilities. We just get in our own way due to our systems.
Okay, thank you. So another question, and this is a question that I'd appreciate everyone's input on. Are there any notable trends or changes in the incidence of diabetes-related kidney disease observed in recent years, and what factors may be contributing to these trends? I have to admit, I don't know of recent data, let's say since 2020, on the incidence of diabetes-related kidney disease. Wondering, maybe Dr. Lake, Professor Pollack, you might have some information about this. If not, we'll have to see. I mean, there have been a more widespread use of SGLT2 inhibitors in higher income countries, GLP-1 receptor agonists. I'm guessing that there may be a decline, but I think time will tell here.
If I can step in then, I think there's been a decrease in the incidence, but an increase in the prevalence. And that's partly because of the increasing prevalence of diabetes, driven by the increasing prevalence of diabetes. But hopefully, with increasing awareness, early detection, we'll see a flattening in that curve. But certainly internationally, there's been an increase in the incidence of chronic kidney disease and an increasing prevalence of chronic kidney disease due to the increase in prevalence of diabetes, which is obviously concerning. So we need to decrease the prevalence of diabetes to improve chronic kidney disease, which means that we all need to work together.
All right, thank you. So I have a final question for all the panelists here. In 30 seconds, what would you call on governments to do to address diabetes and kidney disease? And I'm going to go around my screen. You don't see the order, but I'm going to start with Dr. Lakes. What would you call on governments to do to address diabetes and kidney disease? Dr. Lakes.
Mine is a call for universal health coverage everywhere.
All right. That's much. You have many seconds left out of the 30, but anyway, we're going to Mr. Donahoe. What would you recommend?
I would have to say I agree with that, and I think something that was brought up was about testing. I think the screenings are so important, and if you want to talk dollars and cents, that's the best way. Screen, you'll save money due to the other items.
Okay, thank you, Professor Pollack.
Look, I think screening and then education of primary care physicians and of patients to improve health literacy is really key.
Okay, thank you. Dr. Alasiri.
Better manage the resources that you have, especially the time given to each patient. We need more time for interacting with our patients.
All right, thank you. I agree with everything you mentioned. I would also like to see medications that are life-saving made less expensive. I think that would be a big step forward. So that ends the question and answer session, but don't depart the webinar yet because I have some information to show you when the slideshow comes back on. Well, first of all, I want to thank you, everyone. I want to thank the speakers for their participation in this webinar. I want to thank all the participants, and I want to thank the International Diabetes Federation for sponsoring this webinar. And I have more information on the next slides for everyone. Please go to the next slide. Okay, so the recording slides and feedback questionnaire will be sent to all registrants in a few days. Please respond to the feedback questionnaire to help us improve future IDF online events. And also, I'll remind you to get your certificate of attendance if you've attended more than 80% of this webinar. And send any questions you may have to advocacy@idf.org. Next slide, please. So I want to inform everyone about an upcoming IDF online event, Diabetes and Wellbeing Care, More Than Access to Care. It's on May 28th at 1800 hours Central Europe time. And you can register by clicking on the QR code that's shown here on the screen. Next slide, please. And I also want to share this information about the IDF World Diabetes Congress, which is scheduled to be held in Bangkok, Thailand, April 7th to 10th in 2025. There will be 10 program streams and many, many hours of scientific sessions and hundreds of international speakers. A registration is now opened. It opened on April 1. Please note that abstract submissions are accepted between July 15th and September 15th. And then the early rate registration deadline is October 31st, 2024. So I hope to see you all at the IDF World Diabetes Congress. Next slide, please. I think this is the last slide. And thanks again to everyone for your participation in this webinar.